Introduction. Multiple system atrophy, MSA, is a rare neurodegenerative disorder characterized by a variety of clinical features, including autonomic dysfunction, movement abnormalities, and cognitive impairment. It falls within the spectrum of synucleinopathies, alongside Parkinson's disease and dementia with Lewy bodies. MSA is an important condition for medical professionals to understand, as early recognition and appropriate management can significantly impact patient outcomes. In this comprehensive script, we will explore various aspects of MSA, including its classification and subtypes, pathogenesis and pathophysiology, neuroimaging findings, autonomic dysfunction, movement abnormalities, differential diagnosis, alpha-synuclein pathology, treatment options, management of autonomic dysfunction, rehabilitation strategies, prognosis and disease progression, as well as research advancements and future directions. Multiple system atrophy can be broadly classified into two main subtypes: MSA with predominant Parkinsonism, MSAP, and MSA with predominant cerebellar ataxia, MSAC. MSAP is characterized by Parkinsonian features such as rigidity, bradykinesia, and postural instability, resembling Parkinson's disease. On the other hand, MSAC presents with cerebellar dysfunction, including ataxia, dysarthria, and intention tremor. Within these subtypes, there is considerable phenotypic heterogeneity, making the classification of MSA further complex. Some patients may exhibit prominent autonomic dysfunction, while others may have more pronounced Parkinsonian or cerebellar symptoms. The classification is important for clinical management and prognostication. The exact pathogenesis of multiple system atrophy remains unclear, but it is believed to involve the abnormal aggregation of alpha-synuclein protein within oligodendroglial cells. This accumulation leads to the formation of cytoplasmic inclusions called glial cytoplasmic inclusions, GCIs, in affected brain regions. The process is thought to result in the degeneration of neurons and glial cells, contributing to the clinical manifestations observed in MSA. Various mechanisms have been proposed to explain the spread of alpha-synuclein pathology in MSA, including cell-to-cell transmission, axonal transport, and immune-mediated mechanisms. Genetic factors may also play a role in disease susceptibility, although the majority of MSA cases are sporadic. Neuroimaging studies, including magnetic resonance imaging, MRI, have emerged as valuable tools in the diagnosis and evaluation of MSA. Certain radiological features have been identified that aid in distinguishing MSA from other neurodegenerative disorders. These include the presence of putamental or pontine atrophy, the hot cross-bun sign, and the slit-like hyperintensity sign in the pons. In addition to structural imaging, functional imaging techniques such as positron emission tomography, PET, and single photon emission computed tomography, SPECT, can provide insights into the underlying pathology and neurotransmitter systems involved in MSA. These imaging modalities help in the early detection and differentiation of MSA subtypes. Autonomic dysfunction is a hallmark feature of multiple system atrophy and can significantly impact patients' quality of life. It involves dysfunction of the autonomic nervous system, leading to disturbances in cardiovascular, gastrointestinal, genitourinary, and thermoregulatory functions. Common autonomic symptoms in MSA include orthostatic hypotension, urinary incontinence or retention, constipation, and erectile dysfunction. These symptoms are often refractory to treatment and require multidisciplinary management involving medications, lifestyle modifications, and supportive measures. Besides autonomic dysfunction, movement abnormalities are prevalent in multiple system atrophy. Patients may exhibit Parkinsonian features such as bradykinesia, rigidity, and resting tremor in MSAP subtype. In contrast, MSAC subtype is characterized by ataxic gait, dysarthria, limataxia, and dystonia. The movement abnormalities in MSA are typically poorly responsive to levodopa therapy, which differentiates the condition from Parkinson's disease. A thorough understanding of these motor symptoms is crucial for accurate diagnosis and management. The clinical features of multiple system atrophy can overlap with other neurodegenerative disorders, posing diagnostic challenges. It is essential to differentiate MSA from Parkinson's disease, dementia with Lewy bodies, and other atypical Parkinsonian syndromes such as progressive supranuclear palsy and corticobasal syndrome. Accurate diagnosis is possible by considering specific clinical features, neuroimaging findings, and ancillary investigations such as lumbar puncture to analyze cerebrospinal fluid biomarkers. A multidisciplinary approach, involving neurologists, radiologists, and specialized movement disorder clinics, is crucial for establishing an accurate diagnosis. The pathological hallmark of multiple system atrophy is the presence of alpha-synuclein aggregates, particularly within glial cells. These abnormal protein accumulations form GCIs, which are commonly observed in the striatonigral, olivopontocerebellar, and autonomic nervous systems. The distribution of alpha-synuclein pathology correlates with the clinical manifestations seen in MSA. The underlying mechanisms leading to the formation of GCIs and the subsequent neurodegeneration remain subjects of ongoing research. Currently, there are no disease-modifying treatments available for multiple system atrophy. Management primarily focuses on symptomatic relief and rehabilitation strategies to optimize patients' functional abilities. Pharmacological interventions may include dopaminergic medications for Parkinsonian features, alpha-adrenergic agonists for orthostatic hypotension, and anticholinergic agents for urinary symptoms. Non-pharmacological approaches such as physical therapy, occupational therapy, and speech therapy can help improve mobility, activities of daily living, and speech difficulties, respectively. Supportive measures, including the use of assistive devices and psychological support, are also integral components of MSA management. Autonomic dysfunction in multiple system atrophy can be challenging to manage due to its multisystem nature and resistance to treatment. Heat intolerance, orthostatic hypotension, constipation, and urinary symptoms significantly impact patients' daily activities and require targeted management strategies. Approaches to managing autonomic dysfunction may include lifestyle modifications, for example, fluid and salt intake, pharmacological interventions, for example, fludrocortisone, midodrine, and physical maneuvers, for example, leg crossing, abdominal compression, to mitigate orthostatic hypotension. Gastrointestinal prokinetics, laxatives, and dietary modifications aid in alleviating constipation. Furthermore, urological interventions and use of antimuscarinic medications can help manage urinary dysfunction. Rehabilitation plays a crucial role in optimizing function and minimizing disability in multiple system atrophy. Physical therapy aims to improve balance, gait, and muscle strength, focusing on activities that enhance patients' mobility and reduce the risk of falls. Occupational therapy assists in adapting the environment and teaching compensatory strategies to maintain independence in activities of daily living. Speech therapy focuses on addressing dysarthria and swallowing difficulties, employing techniques such as strengthening exercises and adaptive strategies. Additionally, psychosocial support and counseling are important components of the multidisciplinary rehabilitation approach. The prognosis for multiple system atrophy is generally poor, with a median survival of approximately 6 to 10 years from symptom onset. Disease progression is characterized by a gradual decline in motor and autonomic functions, leading to increased disability and dependency. The rate of disease progression can vary among individuals, with some experiencing rapid deterioration and others having a more indolent course. Prognostic factors such as age at onset, initial symptom severity, subtype of MSA, and the presence of certain autonomic features can help predict disease trajectory and guide care planning. Research efforts are actively aimed at unraveling the underlying mechanisms in multiple system atrophy and discovering novel therapeutic targets. Ongoing studies focus on understanding the propagation of alpha-synuclein pathology, identifying genetic risk factors, and developing disease-modifying interventions. Advancements in gene sequencing technologies and the establishment of large-scale collaborative research networks have accelerated our understanding of the genetics and molecular pathology of MSA. Future approaches may involve neuroprotective strategies, stem cell therapies, immunotherapies, and precision medicine techniques tailored to an individual's specific disease profile. In this script, we have discussed various aspects of multiple system atrophy, including its classification and subtypes, pathogenesis and pathophysiology, neuroimaging findings, autonomic dysfunction, movement abnormalities, differential diagnosis, alpha-synuclein pathology, treatment options, management of autonomic dysfunction, rehabilitation strategies, prognosis and disease progression, as well as research advancements and future directions. Multiple system atrophy poses significant challenges in diagnosis and management due to its complex clinical manifestations and limited treatment options. However, a multidisciplinary approach involving neurologists, specialized clinics, and rehabilitation professionals can provide comprehensive care and support to individuals affected by this debilitating condition. Ongoing research holds promise for unraveling the underlying mechanisms and advancing therapeutic strategies, ultimately improving outcomes for patients with multiple system atrophy.